An accurate history taking and a proper clinical examination are very essential skill needed for a good clinician. So in this session, we are dealing with the history taking in ophthalmology. So history taking is an ongoing process starting right from the beginning of the consultation. So a good history always suggests certain differential diagnosis in our mind, so which you can confirm or rule out by your clinical examination and ordering certain specific investigation. So we cannot learn this history taken by a lecture, but it is an acquired art that which will gain only by our clinical experience. So in modern 70 to 80% of the time, you will reach into a conclusion by history alone. So it is the most important and cheapest diagnostic test in clinical ophthalmology. So for a good history taking, we need communication skills, knowledge in the subject, and of course, practice. So what is the importance of history taking? It gives clues to the diagnosis. It helps to focus our clinical examination. And moreover, it forms a good relationship of trust and understanding between the patient and doctor. So we are less likely to be sued in our practice. And what are the different strategies? It could be exhaustive or targeted. So usually the exhaustive means we are asking certain questions under certain headings, like you take the clinical case for a clinical case presentation, whereas targeted means it's a problem-focused, comprehensive interviewing between the patient and the doctor. So always it is an integrated interviewing consisting of open-ended questions and closed-ended questions. Open-ended questions means we are asking the patient to tell their own story, whereas close-ended questions means the clinician is asking certain specific questions according to the problem pointed by the patient. If it is only open-ended question, the patient will keep on telling his story. So we have to guide the conversation by asking certain specific questions. So before starting our history taking, it's a good practice to introduce each other, to make a good rapport between the patient and the doctor. So always welcome the patient with a smile and greet by his or her name. So make the patient comfortably seated and always make an eye contact during your conversation. And it's very important to communicate in patient's language. So what are the components? Among these, the chief presenting complaint and the history of presenting illness are the most important components of history taking. So coming to the personal data, this is the first factor you have to mention in your case sheet. The name and address is very important because for the identification of the patient as well as for research purpose. And the age and gender, certain ocular conditions are more common in certain specific age group. For example, typical optic neuritis is very common in young females of 20 to 45 year age group. And occupation, we are seeing so many worksite injuries in our casualty. Suppose you are seeing bilateral corneal erosions while working in casualty. You have to ask about the history of exposure to any welding fumes. So that is the importance of occupation. And moreover, corneal ulcer is very common in farmers. Coming to the presenting complaint, this is the symptom which made the patient to visit in your OPD. So always record the complaints in patient's words and mention laterality and duration. Always avoid the medical terms, and you have to arrange the presenting complaints according to the importance. For example, a patient is already a non-case of recurrent uveitis, complaining of redness and photophobia for past 1 week. So you have to record the presenting complaint as the redness and photophobia for the past 1 week. So these are the common complaints you can encounter in your OPD. It could be a visual related problem or non-visual complaint. So coming to the history of present illness, this is the detailed history of chief presenting complaints with important associated symptoms and important negative history. So you have to arrange the symptoms in chronological order and always categorize the information and include only the relevant information from the patient. So coming to the common presenting complaints, the defective vision is the most common complaint you can see in your OPD. Then you have to ask the patient whether it is painless or painful. Then next you have to ask about the mode of onset. So it could be a sudden onset or gradual onset. So these are the certain differential diagnoses you will know from your MBBS level. So with these conditions in your mind, you have to ask the associated symptoms and negative history. The next, defective vision will be more for the near, sometimes, especially in presbyopia or some problem with accommodation. Whereas distant vision, you usually encounter in refractive errors and cataract. In cataract itself, if it is posterior polar cataract, it usually, the near vision will be affected more than the distant vision. Whereas in nuclear cataract, the patient will be complaining, means patient will be telling the near vision is better than the distant vision. That is called second sight. Then sometimes the defective vision will be having diurnal variation also, especially day blindness in disease of Cones and night blindness in disease of Rhodes. So sometimes the complaint will be a transient loss of vision. So transient loss of vision means the loss of vision that usually recovers within 24 hours, most of the time within 1 hour. So you have to ask about the laterality and the duration. Suppose it is lasting for seconds, especially unilateral or bilateral, it could be a papilledema. And if it is lasting for minutes, if it is unilateral, it is suggestive of amaurosis fugax, especially seen in impending CRV or giant cell arteritis, etc. And in migraine, usually the transient loss of vision lasts up to 1 hour. Then you have to ask whether it is temporary. Sometimes the uncontrolled, especially young uncontrolled diabetes, will be having rapid intumescence of the lens. So it could lead on to the temporary loss of vision. Once the diabetes is under control, the vision will become normal. Then regarding the progression of defective vision, you have to ask whether it is stable or is it progressing or is it improving. For example, in typical optic neuritis, the vision usually worsens up to 2 weeks, but 2 to 3 weeks, the vision usually starts recurring. Then by 2 months, it becomes almost normal. So that is the typical pattern of typical optic neuritis. Then another most important history is use of spectacle, especially the young, especially in teens, they are complaining of frequent change of spectacle. It is more suggestive of keratoconus. And the other condition in which you will get frequent change of spectacles are uncontrolled diabetes or POAG. The next important complaint is redness. In redness, it could be painless or painful. If it is painless, you have to ask about the nature of discharge. If it is purulent discharge, it is usually bacterial. If it is mucopurulent, it could be chlamydial. And if it is watering, you have to ask another history, that is presence of itching. If there is severe itching, it could be usually allergic. If there is mild itching or there is no itching, it is usually pointing towards viral conjunctivitis. And if there is no there is no discharge with painless redness, it is usually subconjunctival hemorrhage, pterygium, etc. Whereas redness, if it is associated with pain, usually it is a sight-threatening condition. So suppose the patient is telling some foreign body fall or foreign body sensation, most probably it will be, you have to look for the corneal foreign body or corneal erosions. And if the painful redness is associated with nausea, vomiting, or colored halos, it is more suggestive of acute angle closure glaucoma. Sometimes the patient will be having periorbital edema or diplopia. It is more suggestive of orbital cellitis. If there is no such symptoms, it usually pointing towards scleritis, uveitis, or endophthalmitis. So in nutshell, if there is pain, it is suggestive of inflammation, especially the uvea and cornea. It is very sight-threatening. You have to do a proper clinical examination. And if there is discharge, it's usually infectious. So we have to tell the patient there is chance of spread to others. And if there is itching, especially severe itching, usually suggestive of allergic etiology. And if there is watering, it could be due to a viral or chronic allergy pathology. Then coming to the pain is the most important complaint. You can see the in ophthalmic OPD. So it could be related to maybe an ocular discomfort or headache or some referred pain. It's mainly due to secondary to the sinus pathology or some dental problems. So you have to ask the question in this heading. Among these, the timing and characters are very important. For example, the patient is telling it's a squeezing type of headache around her head that is more suggestive of tension headache, whereas a pulsating headache, especially in unilateral side associated with nausea or vomiting, it is pointing towards migraine. And thunderclap headache is very well known for subarachnoid hemorrhage. And suppose the patient is getting headache in morning hours, especially the patient is waking up with headache, is suggestive of some intracranial space occupying lesion. And the deep boring pain of severe pain, especially not making the patient to sleep in night, is more suggestive of uveitis or scleral inflammation. Then coming to other symptoms, sometimes the patient will be having photophobia. What is photophobia? It is a painful aversion to the light, especially seen in inflammation of the uvea or cornea. And whereas the glare is different, it is painless, and it's the difficulty to look into the bright light, especially in some central opacities of the cornea or lens, especially the patient will be having glare, especially during driving time. And colored halos, you all know the causes of colored halos. You have to ask the history. Suppose the colored halos are disappearing with washing your face, it is more suggestive of mucopurulent conjunctivitis. Then diplopia, you can ask whether it is uniocular or binocular. Then coming to the symptoms of posterior segment, it could be floaters, flashes, or metamorphopsia. The floaters, especially if it is moving against your movement, it is suggestive of vitreous floaters. And flashes, especially coming from the temporal side, it is more suggestive of retinal pathology. And metamorphopsia, like micropsia, macropsia, all these are suggestive of some macular pathology. There are certain other symptoms like seeing escotom or visual field defect, or it could be some disfigurement of the eyes like proptosis or ptosis. So all these are the certain common complaints which you can frequently encounter in your OPD. Then coming to the review of systems, this is helpful to assess the general and systemic status of the patient, especially in case of uveitis. Coming to the past history, it is very important. You have to ask about the medical ocular history, that is there any similar complaint in either eye, especially the recurrent corneal erosion, viral keratitis, all these are known for recurrence. Then another important history is history of trauma. Suppose you are seeing a cataract or RD, so you have to ask about any previous history of trauma. And you have to ask about history of any amblyopia or previous episodes of defective vision, and medico-legally also it is very important. Then another history is ocular surgical history. For example, history of cataract surgery or in refractive surgery, especially you are seeing keratoconus, any surgery of cross-linking, etc. Then coming to the systemic history, medical history regarding some lifestyle disease, diabetes, hypertension, COPD, heart block, etc. Suppose you are planning to start timolol, you have to ask important history of heart block or COPD. So you have to avoid such drugs in these conditions. And some infectious diseases like TB, syphilis, leprosy, etc. you have to ask. In systemic surgical history, especially to know is there any contraindication for general anesthesia, like that. Then coming to the family history, you have to ask about the history of similar disease, lifestyle diseases like diabetes, hypertension, and of course diseases running in family. Coming to the treatment history, it is very important. Suppose you are seeing a patient in casualty with a corneal ulcer, especially progressive corneal ulcer, you have to ask about history of putting some steroid eye drops. And systemic steroids are well known for causing a complicated cataract as well as the CSR. And a history of OC pills can lead on to papilledema, idiopathic intracranial hypertension, or papillophlebitis. Suppose we are posting the patient for cataract surgery, you have to ask the important history of taking antiplatelet drugs or some drugs for benign prostatic hypertrophy, because alpha blockers can lead on to floppy iris. It can lead on to some intraoperative complications. Then history of allergies like drugs like penicillamine, sulfonamide, especially while using Diamox, and history of dust allergy. These are all important. Coming to the personal history, apart from bowel and bladder habits and diet pattern, most important one is history of addiction. Example, suppose we are seeing a patient with bilateral pale disc, we have to ask important history of chronic alcoholism or smoking. So in sometimes you have to get information from another person. These are the certain situations you have to get information from other person. And history taking in children is very difficult, especially under 5-year age group. And always make sure the mother is there with the child. And you have to ask about antenatal history. In birth history, it is very important to ask about the perinatal asphyxia, because perinatal asphyxia or infection can lead on to cerebral visual impairment. And you have to ask about the history of fixation problems, delayed milestone, and consanguinity is very important, especially in autosomal recessive conditions. And this is the era of COVID. So you had to get history of symptoms of COVID or any recent travel or contact with the COVID-19 patient. Suppose the patient is coming from containment zone or a high-risk patient, you have to categorize the patient and you have to examine with full PPE in an isolated room. So always find time to listen to your patient, and most of the time he will tell you the diagnosis. So thank you, and thank you for giving me this wonderful opportunity.